Hello, this is Stephen Holloway, Nursing 203, Module A, Congenital Heart Defects. We continue with our heart defects that decrease pulmonary blood flow. This defect is one of the ones that you will hear about quite frequently. It's called tetralogy of flow. Tetra meaning four, because there are actually four type defects that are part of this process. We see that basically 10% of all congenital heart defects are tetralogy of flow. So it is a fairly large percentage of patients, children, that will have these. 15% of these children who have the tetralogy of flow also have chromosomal defects, and it is the most common of the cyanotic defects that we will look at. So let's kind of look a little bit at the pathophysiology. Again, as we said, tetra means four. So this child has four different types of congenital defects. The one that really is the most problem is the pulmonary stenosis. And typically the pulmonary stenosis, again, we talk about here, is the big problem. It can be substenotic, or it can be actually a valvular type stenosis. This child also has a very large VSD, ventricular septal defect. They have an overriding aorta, and really what that means is that the aorta comes down far enough and kind of extends almost into the right ventricle as well through that defect. So as blood is pumping, mixed blood is moving out. We're seeing a mixture of the right and the left, the mixed blood moving into the systemic circulation. That's why we're seeing what we call a decreased blood flow. That's why this is called a cyanotic type process, is because these children do have cyanosis because of the mixing of the unoxygenated and oxygenating blood here. And then again, we see right ventricular hypertrophy, as this right ventricle is having to pump against this type process, trying to pump against the stenotic area. Really, when we look at it, the degree of pulmonary stenosis kind of dictates the timing of surgery and the pre-op management of these children. We talk about this being a right to left shunt. So what we're seeing is unoxygenated blood moving from the right side of the heart to the left side of the heart. And that's a problem as we begin to put unoxygenated blood or mixed oxygenation of the blood out into the systemic circulation. As we look at this, we've talked about the pathophysiology. We've kind of seen some of these type processes, the four type things: pulmonary stenosis, overriding aorta. 10% of these tetralogy is one of those. 15% have chromosomal defects. Clinical manifestations that we see with these children typically are cyanosis, and the amount of cyanosis is going to depend on the degree of pulmonary stenosis. So what we're seeing is as we get more stenosis, the right ventricle is pumping, trying to pump that blood through there. So what it's ended up doing is moving from the right side into the left side of the heart. You may not see this in newborns, but they could have a bluish tint. One of the other things we see is called polycythemia, which is an increase in the number of red blood cells. And that's there because we're actually trying to increase the amount of oxygen carrying cells to get oxygen to the body. But this has a problem of its own. With this increased number of red blood cells, we see an increased viscosity of the blood, so it's very thick, which can cause problems with clotting, thrombosis, embolism, and with strokes, with CVAs. So a big problem as we're looking at those type issues with these children. Other manifestations that you may see is because these children have these cyanotic effects, they're called TET spells. Basically, it's really hypoxic. And what happens is when these children have these TET spells, they'll actually, if they're older children, will assume a squatting position or a knee-chest position. This really helps to shunt the blood back up to the heart and get the blood moving back to the pulmonary circulation. They can have syncope or fainting. because of the decreased oxygenation to the brain. And a lot of times that'll occur with crying or with exertion. And again, kind of with these hypoxic episodes that goes along with that, that's what's causing the fainting, these TET spells. Again, we'll see that usually with crying or with exertion. The hypercyanotic episodes of TET spells, again, thought to be due to decreased pulmonary blood flow and increased right to left shunting. So we'll see some of those. Even with mild pulmonary stenosis, we've got a decreased pulmonary blood flow, and you can see some cyanotic spells with these children. So it is quite frightening to the parents when these children have these episodes, because they will kind of turn blue during that time frame and get hypoxic and can pass out from it. You see a nurse here holding a child that probably had been having a TET spell, maybe had turned cyanotic from the crying. She's comforting and then kind of putting that child in that knee chest position to try to help get that recirculation going per se. So what do we do? How do we diagnose these children? Again, what we're doing, we notice the signs and symptoms when they're born, listening to those large murmurs, seeing the hypoxia, seeing the cyanosis, and then we begin to do more diagnostic labs. Of course, a blood count is going to show the polycythemia with increased hemoglobin, hematocrit, and RBCs, along with the decreased oxygen saturation. Chest X-ray may be normal, or they talk about what's called a classic boot-shaped heart. Kind of hard to describe. I wish I had a good picture to show you, but I can't find a really good chest X-ray to show you that. An echocardiogram is going to show right side hypertrophy, decreased size of the pulmonary artery, and decreased blood flow through the lungs. A cardiac cath is really the definitive type process, because through that cath we can see all of the defects that are there and know what size they are, to really begin the plan for treatment on these children. When you listen to them, you're going to hear a murmur all over the left, anterior, and posterior sides of the chest. Very, very prominent type process that you're going to hear, murmurs you're going to hear. Just a little thing to show you. Tetralogy of flow is one of the cyanotic defects, congenital defects. We've got a right to left shunt. And typically these children will have these squatting type things when they're resting. It kind of helps. They'll be cyanotic. And if we're older children, you're going to see clubbing of the fingers. Okay. So treatment, typically if the child is having one of these TET spells, we want to get them in the knee chest position. We want to get them on some oxygen and give them a little bit of morphine. The morphine actually helps decrease that pulmonary vascular resistance and helps with the circulation of the blood through there. Without TET spells or just hypoxic type spells, may use Inderol, a beta blocker, to help dilate the vessels. And we want to do volume resuscitation on these children, because many times if we're seeing them dehydrated, we can do that. You want to teach the caregivers, about these knee chest positions, keeping the head up, because this will decrease the systemic vascular resistance and return blood to the heart. Now, hopefully it also decreases the right to left shunting and increases blood flow to the lungs. You need to be very careful, but you got to increase that volume to decrease the viscosity of the blood. And infants, of course, are very prone to overload, so a real good measurement of their intake and output is very, very important. If these children have a low blood pressure, you may see neosynephrine, phenylphedrine used to increase the blood pressure and increase the systemic vascular resistance on these children. Definitive treatment typically is surgery for these children. Most of these children have surgery approximately 3 to 12 months of age, but it's going to vary. Typically, they're going to try some of the temporary palliative type procedures, so we can help with these children and get them situated for the big types of surgeries that's going to be happen. One of the things we want to try to do is we want to try to keep that ductus arteriosus open. We want to keep it patent. because it creates a shunt across that area. So a lot of these children will also get the prostaglandins to help keep that ductus arterius open. One of the things that they'll do is called a Blalock-Halsing procedure. It's temporary and it's palliative. It basically creates a shunt using the subclavian artery between the pulmonary artery and the aorta, equals blood flow of the PDA to the aorta and to the pulmonary arteries for the left side of the heart. When you do that, there's no palpable pulse in the right arm related to the use of the subclavian artery for the shunt, so be aware of that. You don't want to take any blood pressure or venipunctures in the arm. Typically the right arm they do for that. Another palliative type process that they do is called the Brock's procedure. The Brock's procedure relieves the pulmonary stenosis, repairs the VSD, and the overriding aorta. That's the definitive type one that you're going to see on these children. Again, the time of that is going to be very complete repair. Usually is performed between 3 and 12 months of age, but varies. The goals of the repair: to widen the ventricular outflow tract and to close that VSD. So you're going to be seeing some of those type processes. The surgical mortality is between 2 and 5%, so actually has a very good mortality rate if you look at it that way. Approximately, as we look at it, these children who basically have the surgery do very well and live long, productive lives. Long-term complications can occur, and they can be ventricular arrhythmias, of course, heart failure, and sudden death. And again, we're seeing more and more. The problem is if the children don't have surgery, only about 11% live past the age of 20, and only 3% make it to the age of 40. They will have severe dyspnea, growth restrictions, clubbing the fingers, and again, they can have the ventricular dysrhythmias, everything that goes along with that whole process as they grow and the changes occur within the heart and the outflow gets worse. Again, just as we kind of summarize, these children typically have some sort of chromosomal defect. There are four defects that are seen with tetralogy of Fallot, and the whole thing is that it's a right to left shunt because of the pulmonary stenosis. The pulmonary stenosis really drives when we treat these children. The ultimate goal is to repair that stenosis, to repair the ventricular septal defect, to repair that overriding aorta, so that we can actually get blood flowing quickly. Thank you for your attention. This completes Tetralogy of Fallot. So we'll be talking about some other issues. This is just kind of a different type of way of looking at it. These are some of the different ones. Now, there are a couple of other congenital defects that I want you to read about. These go along with that defects that decrease pulmonary blood flow, and I want you to read about transposition of the great arteries, and I want you to read about tricuspid atresia as part of your reading assignment for this. You are responsible for that material, and there could be test questions based on that. So good luck, and we'll move on to the next one.